Gitelman syndrome and Bartter syndrome both are hereditary syndrome where there is hypokalemic alkalosis. Bartter syndrome is an autosomal recessive disease where there is defect in ascending loop of Henle. There is defective reabsorption of sodium chloride along with that water. Therefore, there is increased urinary excretion of sodium water leading to salt wasting polyuria. Therefore, decrease in sodium and water in body leads to hypovolemia and decreased blood pressure. Also, there is increased urinary excretion of calcium ions leading to hypercalciuria or nephrocalcinosis. These changes will stimulate RAS system which activate aldosterone in order to increase the absorption of water. They act on thick ascending loop of Henle, Romke channels, and also on DCT. Now, with increasing the water reabsorption, they also increase K plus and H plus ion excretion, therefore leading to hypokalemia and alkalosis. There is also increase in prostaglandin excretion seen in these disorders. There are depending type of channel mutation, there are 5 type of Bartter syndrome. If sodium chloride and KCl channels are co-transporter gene is mutated, is type 1. In type 2 we have mutation in ROMK gene. In type 3 there is mutation in chloride channel gene. In type 4 there is Bartin protein gene mutation. In type 5 there is chloride channel which is calcium ion sensitive receptor chloride channel mutation is seen. The milder form of this syndrome is Gitelman syndrome. It is also an autosomal recessive disease where there is defect in DCT part of nephron. There is problem with sodium chloride co-transporter leading to increase in water and sodium excretion in urine. There is similar features as seen in Bartter. There will be metabolic alkalosis, hypokalemia. Also, there can be hypomagnesemia, but calcium in urine is less, that is hypocalciuria. But this calcium may get deposited in muscles, tendons, and cartilage, leading to chondrocalcinosis, leading to some neuromuscular symptoms such as fatigue, weakness, carpopedal spasm, tetany, and cramps. This is an important differentiating between this Bartter syndrome and Gitelman syndrome. It is a milder form of Bartter syndrome with late onset. Bartter is early onset with maternal hydromenos can be seen, polyuria, polydipsia can be seen, dehydration can be seen, tetany is not seen, growth retardation can be seen. Whereas in Gitelman we have late presentation, there is no hydromenos, polyuria, polydipsia is rarely seen, dehydration is not seen, tetany can be seen, there is no growth retardation. Common to both these syndromes are there is increased hyperplasia of JG apparatus, renin activity is increased, aldosterone activity is increased, there is metabolic alkalosis, BP can be high, low, normal. Response to angiotensin 2 is seen in both with decrease in blood pressure. Serum magnesium is decreased in both. Serum potassium is also decreased in both. Whereas serum calcium can be normal or decreased in Gitelman. Urinary calcium is an important differentiating factor. It is normal in Bartter, whereas hypocalciuria is seen in Gitelman. Urinary PG, the prostaglandin is normal or can be increased, whereas it is normal in Gitelman. Nephrocalcinosis is a feature of Bartter. It is not seen in Gitelman. Furosemide is a loop diuretic. Since in Bartter we have defect in loop diuretic, there is no response to furosemide seen in Bartter syndrome, whereas response is seen in cases of Gitelman syndrome. Thiazide diuretics they act on DCT. Therefore, since Gitelman is a disease of DCT, there is no response seen with the thiazides, whereas in Bartter there is response to thiazide diuretics.